second guest. Welcome to all the fellows nationally, and I believe we have some fellows that have signed in from the other countries within the continent. Welcome to the platform, and we look forward to your participation for the next 2-year cycle. My original plan was never to be in this meeting welcoming you every single time, but for the facilitators to do that. But the reason that I've joined this evening is that the last time around, I had hoped that I'd be able to ask all of you to put on your cameras, to introduce yourself, which center you're training at, and how far you are in your training. The reason I didn't do that was because I was concerned about time. I felt we had a lot to cover, and I didn't want us to lose any time. I do still have the same concern today. This is a huge topic, and there's a lot to get through. So rather than asking you individually to introduce yourselves, I feel that over time we'll get to know each other. With the individual presenters can tell us who they are, which center they're at. But perhaps for today, it's a great idea if all of you would please put on your cameras so we can see who you are, see who the faces are behind the black screens. And you can just all wave and say hello. And as I say, over time, I'm sure we'll all get to know each other quite well. But wherever you are, welcome this evening, and thank you so much for joining. I think today's session is very, very exciting, and I know you're going to enjoy it. And we've sourced the best person, truly the best person that I know of, who understands this topic, is passionate about it, and really just wants everybody to understand motility. It's such a key part of our practice as gastroenterologists. So I'm not gonna delay this any longer. I'm going to hand over to Dr. Sassa Botha. We just call her Sassa, and she's going to run the show. Sassa, over to you, and thank you once again.
Okay, so I'll just share my screen. Okay, there we go.
Yeah, we can see it. Excellent. Thanks, Sassa.
Remove this a little bit. Okay, hi. I'm, as you know, now I'm Sassa, and I work at the gastroenterology unit here at Groote Schuur Hospital, and I manage the motility unit here. The topic is actually dysphagia, but I decided to be able to sort of bring in what I do. I'm going to sort of combine everything and sort of have a more practical approach to dysphagia, and through that using my high resolution manometry. So today it's about high resolution pressure topography manometry and the application in a practical setting. Oh dear, let me just see. Okay, so I've traveled a very long road since 1993 when I started with manometry, but I sort of thought I won't take you on that long road, and I'll take a faster route for you. So the aim is really not to confuse you, and I'm going to try and touch on the history and development of manometry, the paradigm shifts that happened because of this with the classifications, the metrics that we use in high resolution manometry, pattern recognition, indications for high resolution manometry, and then try and do the more practical side by using case studies. And poor Innocence is going to have to answer all my questions. So history-wise, in the 1950s, this Ardendorff low compliance pneumatic hydraulic perfusion system was introduced commercially, but they used, at that stage, they used catheters with 4 to 6 channels, and we had a linear, we just used linear tracings. Over the years, you know, when I started with the Ardendorff pump, we were still using DOS. I don't think you even know about DOS as the computer language we were using. But luckily, PCs developed, and through that, the software programs developed, and with Windows, and then all the systems became far more streamlined and more practical. But they were still using just the catheters with 4 to 6 channels, and still just had linear tracings. So in the early 1990s, there was a man called, he was Australian, and he was called Ray Klaus, and he was the man that instigated high resolution. I just want to make this a bit smaller. I don't know if you see, yeah. He developed the high resolution manometry. And what high resolution means, it's all they did was they just increased the channels. So from instead of 4 to 6, we now have 12 with 36 channels in our catheters. But then it was still very complicated because it was a linear tracing. But then he designed or developed the so-called Klaus plots. And basically what it is, it's very much like a weather chart or a mountain where you sort of connect all the pressures. And if you've got a pressure of 30, then there is a barocontour plots would just measure them all or link them all, and you then get this beautiful picture or pattern, and it made it very much easier to interpret. Oops. So currently, this is the systems that is available. We have a water perfuse system. And how that works is that you've got your external pressure transducers. And where we are in Africa, I must admit, I prefer using my water perfuse system because I can maintain it myself. If anything goes wrong with one of these pressure transducers, I can replace it. And it's actually, very economical. And even buying your catheters is much cheaper than your solid state, where your pressure transducers are inside your catheter. And these catheters are incredibly expensive, and you can only use them 200 times. And unfortunately, you've got to be very careful when you use them. And quite often the channels get defective, and then you've got to send these catheters off to Europe to be fixed. So that is a real problem. So with all this development of software and systems, of course, there was a paradigm shift in the classifications for motility disorders. I'm not going to go into each one in detail because I did send you the articles that you were supposed to hopefully just browse through. So what I'm going to do is I'm going to concentrate on the differences between the Chicago 3 that we used previously and now the Chicago 4. I was very lucky to actually have been at the consensus meeting of the Chicago 2 and 3, and we were supposed to have the Chicago 4 meeting again in Ascona, but then came COVID, and so we couldn't have it. Okay, so the difference between the 3 and the 4 is that now we've got a primary and secondary position when we perform the study. Previously, we just did it in the supine position. Now we do it in a primary supine and a secondary upright position. We now have to chase a symptom. So we move on. We first do the primary, and if we don't get an answer, we go on to secondary. And if we still don't get an answer, we add provocation tests to that, and then we end up doing solid swallows and solid meals, and to try and elicit the symptom. We don't have major and minor motility disorders like in the Chicago 3, and the OGJ outflow obstruction is better defined, and ineffective esophageal motility is now, the definitions are more stringent. So by just looking at this, you can see here's the primary position. So the protocol entails that we first have a sort of rest period where the person can get used to it. Then we let them give deep breaths so that we can see that we've crossed our OGJ. And then we do the 10 boluses of 5 ml of water. And then at the end of that, we do the first provocation test, which is the multiple rapid one. With the secondary position, you have the patient sit up, and then you go through the same process of first getting them stabilized, and then the 3 deep breaths, and then you do only 5. You only do 5 wet swallows. But here, the provocation test that you do here is a free drinking test where they drink 100 to 200 ml of water. To link up a little bit with what you did on the previous Monday is just to remind you that your upper esophageal sphincter and the proximal part of the esophagus is a striated muscle. In other words, under the wool, and the body of the esophagus is a smooth muscle. And you've got to keep that in mind when you do your pattern recognition, and if you want to sort of link it to a condition. So the two bands that sort of anchor our plot is the upper one, you can see here, is your upper esophageal sphincter pressure. And down here, we've got our lower esophageal pressure. And in between, we've got the body of the esophagus and the peristaltic contraction. The Chicago, before we can actually go on to discussing the patterns or anything of the high resolution, you have to know the language, and we've got to speak the same language with the same vocabulary. So you've got to know the metrics that we use in high resolution manometry. And you'll see the classification is based, the most important metric is the first one, IRP, integrated relaxation pressure. So the integrated relaxation pressure is there to see how well how completely the LOS relaxes. And how you do it is it actually measures the 4 lowest periods of pressure in a 4-second period over a 10-second period of time. So in other words, if you've got a 10-second little block here, the computer will look for 4 seconds of the lowest value, so that you've got, it can either be sort of all together, or it could be 4 separate low pressures during this 10-second period. And that is very, very important, because that's your cutoff point as to your Chicago 4 that they grouped as disorders of outflow and disorders of peristalsis. The other thing that you've got to realize is that every system, so if you're using like I do, the Laborie system, or if you're using a Given or a Sandhill or a Mano, each system's values are different. And you've got to make sure that you use your value that works for your system. And then you've also got to realize that there's a difference between water perfused and solid state. The solid state values are usually a little bit higher. So the value, my upper limit of normal is 18 millimeters of mercury, and our solid state value is 19. But for instance, I know Given's IRP value is 15. So they're all different. You've got to be very sure that you're using your right value. Then the next metric that's important is your distal contractile integral, and all that is actually is the force or the vigor that your contraction, your peristaltic contraction is happening. And then distal latency, that's important. That it's measured in time. So it's from where your upper esophageal sphincter relaxes. You measure that from there to the contractile deceleration point. Now the deceleration point is just the point where your peristaltic contraction actually starts to slow down. Now that coincides with, if you're doing your scope, with the ampulla in the esophagus. So this section is the ampulla, and you can clearly see how that the peristaltic contraction slows down there. So your distal latency, if it's less than 4.5 seconds, it means you've got a premature contraction. That means spasm. I've sort of covered the contractile deceleration point. So the most important thing to me is the IRP. You must always start with your IRP. So as I said, the Chicago was, it's grouped it now in disorders of outflow obstruction. That covers your 3 achalasia types and your OGJ outflow obstruction. Disorders of peristalsis is absent contractility, distal spasm, hypercontractility, and ineffective esophageal motility. So we're first going to cover the disorders of the outflow obstruction. And as I said, I wanted to try and recognize the patterns. So as I said, the most important thing we look at is your IRP. And if the IRP is increased, in other words, more than 18, and you then go and look at your peristaltic contractions and it's failed, then you know this is a type 1 achalasia. Type 2, you've also got an increased IRP. You've got failed, 100% failed contractions, aperistalsis, but now you've got 20 or more % of your, after your swallow, you will see there is pan-esophageal contractions. That is the intrabolus pressure that occurs after the swallow. And that is where your pressure is, your isobaric pressure is 30. And that pressure has to stretch from the LOS straight up to your UES. Can you see? So this area, everything in here and inside is 30 or more millimeters mercury. And that is your so-called type 2. And then your type 3 is again increased IRP. You still have failed contractions, but 20% of these contractions, you will see that they are spastic contractions. And that is called your type 3. So they also describe it as your type 1 as being classic achalasia, type 2 achalasia with compression, and type 3 spastic achalasia. And if you look at your barium swallow, typically your type 1 has got a very dilated esophagus, and it's got a bird beak experience, bird beak distal part. And then the type 2, you'll see it's not as dilated, but it still has the bird beak deformity here. And then typically the spastic one looks like a corkscrew when you look at it. Your OGJ outflow, the difference here is that you have now got an increased IRP, but you've got normal peristaltic contractions, and your DCI must be over 450 before you can say that's, it's an outflow obstruction. Disorders of peristalsis, we've got the failed peristalsis and the premature contraction. So they basically look a lot like your type 1 and type 3 achalasia, but the difference being here, your IRP is below 18. And then you've got your hypercontractile contraction, where the DCI, your IRP is below 18 and the value, and then your DCI is 8,000. Your ineffective esophageal motility, there are two sort of types, where you have 70% of weak contractions. Weak contractions mean that your DCI it falls between 100 and 450 millimeters mercury, or it can be a fragmented contraction. So in other words, your isobaric contour, that's the line, your 20 millimeters mercury pressure, you measure it in the 21 for fragmented. The gap between your proximal and your body of your esophagus, that gap is more than 5 centimeters. Then it can also be 50% of failed contractions. A failed contraction is where your DCI is less than 100. And all of them are then grouped as ineffective esophageal motility. So I mentioned the provocation testing. So the two that we do, the one with the primary is the multiple rapid swallows. And that is actually to see if there's peristaltic reserve. So if you're doing your study and the motility, you've got a lot of weak contractions, then you're worried, is there any reserve, peristaltic reserve? And that's when you give them the multiple swallows, which entails that you give them 2 mils 5 times quite quickly in sequence. So they've got to swallow, 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 and then you'll get the inhibitory effect of the LOS. And then once you've given your last swallow, you get your clearance contraction. And that has to be a nice, strong, normal contraction with a normal DCI of at least 1,800. If we, with a secondary position, we do the rapid drink challenge, and that is where we want to look at if there or demonstrate if there is outflow obstruction. If we had a few in the primary position, we had a few contractions that we were wondering, could there be some outflow obstruction here? Then you give them the rapid drink challenge, and what you'll see is your IRP will increase, and then you'll quite often see that you get panesophageal pressurizations, and your DCI can increase to a hypercontractile contraction. The non-manometric investigations, these we actually use if we've got an inconclusive result with our high resolution manometry and we need extra investigations to help us. I'm not sure if you know the time barium swallow. So basically what they do is they give them barium, and at 1 minute, 2 minutes, and 5 minutes, they measure, here you can see, they measure the column of barium to see if there is a delay of the bolus of barium. The endoflip is a very nice, interesting tool, and it actually measures compliance. So it actually, of the LOS, so it actually works very well where you suspect achalasia or a stenosis. And interesting enough, where the IRP looks at relaxation of your LOS, this actually looks at the opening of your LOS. Sadly, we, as far as I know, we haven't got it in South Africa, but my mentor, Prof. Bredenwood of Amsterdam, he feels we can get far with just doing our timed barium. So the indications for high resolution manometry, it is a definite evaluation of unexplained esophageal symptoms, non-obstructive patients with non-obstructive dysphagia and non-cardiac chest pain. I'm not going to cover or include oropharyngeal dysphagia. That's a talk all on its own. Then we also use it for accurate placement of our pH catheters. Also very important, we've got to do a manometry before you do plan a fundoplication, because you want to see that the peristaltic function is normal. Otherwise, they can develop dysphagia post-fundoplication. As in such a case post-operative, if they then develop dysphagia, we repeat the manometry. Evaluation of rumination, we can actually give them a solid meal, and then we can actually induce or show that they have what we call R waves to induce vomiting. Follow-up of achalasia after therapy, especially if the patient then becomes symptomatic again, then you want to know where you stand. Was your therapy successful or not? And evaluation of scleroderma, we use that to see the extent of the scleroderma's effect, because if it affects your esophagus very badly, you know that soft muscle in the vascular system is also affected as badly. And they're starting to use this as well before doing bariatric surgery. Right, so that is my talk. I hope it gives you a little bit of a background as to the pattern recognitions and the metrics we use, and then also, yeah, as I said, the biggest thing is the Chicago classification, and as to where we use the Chicago 4. I must just say that Chicago 3 to me is a much practical, it's a much simpler, more practical one than the Chicago 4, because as soon as you do the Chicago 4, it increases the time of your procedure terribly. And we haven't got normal values yet. So it's all about eliciting a symptom and to see if there's a pattern that you can recognize that occurs when you give them, when you have them in the upright position, or if you give them solid swallows or solid meals. Right, so Innocent, so here is our, I need to see if I can get If I can see him. I can't see you. Oops. Have you unmuted yourself, Innocent?
Yes, I've unmuted myself now.
Okay, so here is our first patient, 45-year-old male that presented with bolus obstruction for the past 3 years. There were 5 episodes more recently, and the last one, he actually needed a manual decompaction of the food bolus using a gastroscopy. So what would you like to know more about his history?
Well, because of the long-standing history of 3 years, even though he's 45, it's not really elderly, but I still want to find out about red flags in these patients.
Yes.
I want to look out for history of weight loss in these patients, family history of non-benign pathology as well. I also want to be sure that it's nothing like anemia in these patients as well. I want to also look back to find out from the previous record about these patients. So I'll be looking for red flags because I want to exclude non-benign pathology.
Yeah, and what else? What could also affect your ability to present like this? What else would you like in the history?
Then I also wanted to find out from the history, because they said it's bolus. I also want to know whether if he's able to tolerate liquid as well, compare between liquid and solid food as well, if he's able to tolerate either of them. Because I just want to be sure that if he's able, if he's able to take in liquid and then maybe just with solid alone. That is on one part as well.
What else is quite an important question you've got to ask them as well.
Then I also want to find out, because he's been on for long, if he has been taking PPI as well, and if the PPI in any way has also helped his symptoms as well.
Okay, so in other words, you're going to ask him about if he's had reflux symptoms or not. But there's one other thing that you've got to ask, so that we actually should ask always about our patients in their general history.
On general history, I also want to find out, I think things like history of cancer in the family, and then also history of smoking as well.
Yes, smoking and drinking. And
I also want to exclude that as well in his family.
One more thing.
One more.
Yeah. Okay, I'll tell you now. Okay, and okay. Once you've asked all of those questions, what investigation would you send him for next?
Yeah, for this person, he said he had 5 episodes of this with one needed gastroscopy with manual decompaction of the food bolus. I want to do for him. I want to do a barium swallow in this patient first.
Okay.
To see, yes.
So you were right with all the danger signs. We like just always to do that. The heartburn symptoms, because that can affect your motility. The one you should have asked about was the comorbidities. You know, has he got a disease, diabetes, things like that, and then also food allergies. Okay, so the procedure, it's difficult. It depends on when you see this patient, So I know in our clinic, if you see a new patient with a history like that, they are here, then we tend to scope them first. But I think the theoretical one is that they usually do, there are no danger signs, and you don't think it's a obstructive cancer or something like that. Yes, they tend to first do the barium swallow and then move on to the gastroscopy. Okay, so now we've got the barium, we've got the gastroscopy, and essentially it was basically a normal one, and the barium swallow was also normal. So what would be your next investigation?
If it was normal, what I want to do is to do want to do a pH test. I'll do manometry first, then yes, Dysphagia manometry.
Okay. Okay, so here we've got our high resolution manometry. If you like, what is the most important one? Have we got to do with outflow obstruction here?
Yeah, from the story, it looked like an outflow obstruction. So I want to look at the IRP in this patient to see if it is normal or.
Okay, here we've got our IRP, and what did I say was our value? That
our value is 18, and this is 9.
Very normal. Okay.
So this is very, very normal.
Okay, so now we've covered our outflow. So now we've got to move to our peristaltic side. And what measurement do I look at there?
So for the peristalsis, I want to look at the DL, the distal latency.
Yes. Okay. So you want to exclude what is a spastic contraction that can also.
Yes, and the zone is 5.8, which is also normal as well. It is more than 4.5. So
what else would you want to look at?
I also wanted to look at the distal contractile integral as well.
Yes.
In this patient, which is the DCI.
Okay, so in other words, it's a normal IRP, normal distant latency, and a normal DCI. So what would you call this?
So this is normal. So look more like functional pathology. But I will still move ahead to possibly do the pH at this point, possibly to see if there is a reflux or not, or it's just functional.
Okay. So this is just a single swallow to show, this is the box of the DCI. Here's the box of the IRP. And here's the little intrabolus pressure that you can see that's quite normal as well. So so you sort of, before we go on, you also do the multiple rapid swallow here, but just to see if there's any reserve, if anything changes there. And then we do, if it's sort of more a straightforward one, I tend to just do the primary position. If it gets complicated, then I go on and I do the secondary position as well. So here I gave him a free drink, and you can see clearly that the IRP is stayed negative. So yeah, it was actually negative. It was totally relaxed. So there's definitely it's a normal manometry with no outflow obstruction, good peristaltic reserve. So okay, so now what will you do next?
Yeah, the next thing I'll do is to do the pH, 24-hour pH monitoring, plus or minus impedance.
Okay, but what we missed that should have been done the day that he was seen with a bolus obstruction. Must always, with anybody, especially males, especially younger males, you've got to do biopsies to exclude eosinophilic esophagitis. So you've got to. So the person who did the bolus obstruction one should actually have done biopsies as well. How do you take your biopsies for EOE?
So first is that the person must be off PPI for at least 2 weeks. And then you take biopsies in the lower and then in the mid segment. You take these 4 to 6 biopsies. So lower side and then also in the mid as well.
Yeah, I think 4 on every level is good. Why do you do the proximal and the mid one and not just the distal one?
I think they say that the yield is better with these 2 segments when they compared to it. I think it is more with the mid one, and then the next segment is the proximal, but it is less with the lower segment. So
typically, because with plain normal reflux, you can also get eosinophils. So that's why they want you to do the mid and proximal. And how many eosinophils per high, whatever, must you get?
15 eosinophils per high power field would be diagnostic.
Yes. How many?
15.
Yes, more than 15 and more. Okay. I just wanted to think. Okay, and if you're looking for EOE in the esophagus with this history of bolus obstruction in a male, what can you see?
So you see, if there is a significant one, because one, it can appear normal and you may not see
Yes,
anything.
like his was normal, yeah.
Yes. But if you see the significant one, you see what they call the trachealization of the esophagus. That is the one that is more profound, and you see it if it is there. But otherwise, most of them might appear normal.
Yeah, but the typical one is you get these sort of linear grooves, and you can get, it looks like candida, but it's not. It's like little deposits that you see there, and you can get a ring. And if it's very bad, they actually can present with a stenosis, you know. So, yep. But the important thing is anybody with dysphagia, you have to exclude EOE. It's very important. Once you've excluded a cancer, I mean, EOE is the most important one. Okay, so we did a impedance pH study to exclude reflux, and it all came back negative. So how would you manage this person?
And this is more of a functional pathology at this point, and I will want the speech therapist and then counselors to get involved to be able to counsel him properly.
Yeah. You unfortunately sometimes it's called functional dysphagia. You sometimes just get an unexplained one without a reason, and it's very difficult. So we usually send them to a speech therapist to try and get them to relax while they swallow, and reassurance that it isn't something very dangerous, you know. And then they do quite well. Okay, right. So here we've got a next one.
So it's a 55-year-old gentleman who presented with a sore throat, but had noticed that the food got stuck and he would vomit a month prior to his admission. Several symptoms are those of dysphagia occur with solid and liquids. Dysphagia and regurgitation occurred with each meal. Lost a lot of weight in a short period of time, 9 kilograms. No chest pain, no heartburn. Was admitted for IV fluid treatment to hospital. Was consulted by ENT surgeon who requested a barium swallow. The barium confirmed achalasia. Gastroscopy findings, a tight OGG. What procedure will you ask for the next? What is bothersome in this history?
So I just want to say the ENT surgeon was good, because at least he didn't just look at the sore throat. You know, he listened to the fact that this man was complaining of dysphagia. Okay, yes. So we know it's achalasia. So what procedure would you ask for next?
So I'll ask for esophageal manometry in this patient. Just to see to make real assessment.
What are you thinking?
Yes, it can be achalasia, though one of my worries is a significant weight loss in this patient.
Yes. Okay,
so that is
that
concerning whether it's a primary or it's a secondary achalasia. So that's one of my concerns.
That's right. No, that's good. Okay. So that's why we said it's a short history, sudden oncome, you know, with the symptoms with very fast progression, the weight loss, age. Those are all danger signs that we've got to exclude and make sure that it's not a secondary achalasia, you know, sort of CT scan or abdominal sonar. Okay, so we know it's achalasia. So why are we doing high resolution manometry? I mean, we saw the barium, we saw the history. So why are we doing it?
Again, I'm not sure the basis for the diagnosis for the achalasia, but again, you can't really say you have achalasia until you do a manometry and you establish it the manometry. You can have other mimickers of achalasia. So Yeah, so if CT scan is fine and I don't see anything, then I will do manometry to establish the diagnosis of achalasia.
Okay, so the big reason why we do the manometry is to classify the subtype. Okay, because subtype, that's achalasia 1, 2, or 3, is going to help us make a decision as to how we're going to treat this patient. Okay, so now here we've got, you can actually just eyeball this and tell me what kind of achalasia have we got here.
So when I'm looking at the IRP, so the IRP is high, is 45. So that is yes. So the IRP is high in this patient, which is in keeping with we'll take a laser, you can go for it.
And what is not there?
I'm looking at the, if there is no, I'm looking at the peristalsis to look at it, if there is.
And do you see any?
No, I don't seem to see, no.
No, that's right. So it's aperistalsis, increased IRP. Okay, I'll
Which is in keep, which is going towards that, which is more in one.
If I look here, what here he swallowed, and what do you call this? It's a intrabolus pressure, but it's a special one. Goes from there to there.
So it's a pan pressurization in this one.
Yes, panesophageal pressurization, and you can clearly see there were more than 20%.
Yeah.
So what type does that make you?
That makes me type 2.
Type 2. Okay. Right. What treatment options have we got for achalasia?
Yeah, you for achalasia is surgical, so I'll use either use a intraoral myotomy. Yeah, so you can do myotomy surgery, yeah, for achalasia.
And the one we actually do more surgically. There's only one person who can do the poem, and that's Galia.
That is Galia.
So in South Africa, in Europe, they're using that more and more. But here with us, what surgical option do we use?
I know it's still a myotomy, but
it's still a myotomy, but what's it called? It's a laparoscopic procedure, and compared to the poem that you go through the esophagus. But so what is that one called? The myotomy. It's the Heller's. Okay, Heller's myotomy.
Oh,
so, okay.
Gilles myotomy. Okay.
Yeah, so we've got a surgical option, the 2 surgical options, and then what else have we got? What other option have we got?
I think that in terms of the other ones, in terms of medical treatment, the outcome has not been so good.
Poor. Yeah, so that's really low down. And what other one is second to surgery? Some the European people tend to do this other procedure more, or they like doing it. So you don't know, you haven't seen one here, have you? I must admit, we don't do a lot of them.
I've not seen, so I want to know.
Okay, so I'll show you. So in other words, pneumatic dilatation. Okay, it's the balloon where they just, blow it up to a pressure of 30, or they start with 30, and then they take out the waste, so it's into the problem with this is you've got to repeat it. So if you dilate, then you've got to bring them back 2 weeks later and dilate to 35, and then wait another 2 weeks. And if they stay asymptomatic, fine, and then you must follow them up. But they do tend to come back with symptoms, and you've got to dilate them every 2 or 3 years. So if you've got a young person, I must admit, here we tend to do a Heller's myotomy, or the choice, Dr. Chinnery usually gives them the choice if they could have a Heller's, because with a Heller's, you can do a partial wrap. so that you don't reflux. Because remember, you're going to cut through the LOS and to take away the resistance that's causing the dysphagia. But now you can reflux as well. Okay. And then it's the poem. Where would you use Botox?
Yeah, you can use Botox
when would you use Botox?
You can use Botox for the elderly ones who are not fit for surgical intervention, or you then you can go for Botox.
Yes. Or if they very their weight is very low, then we also tend to give them Botox. And you must just remember that the complication of pneumatic dilatation is perforation of your esophagus. So in other words, you know, the patient you want to dilate must be able to have surgery as well. Okay, because if you perforate the esophagus, you have to go in and operate and fix it, you see. So it's very important that they've got to be healthy enough to be able to withstand surgery. Okay, here's another case. So this is a 24-year-old female student. She gives a 6-month history of difficulty swallowing certain foods and fluids. Past 2 months, it has got progressively worse. So the solids and fluids get stuck with each meal. A few times a week, she experiences regurgitation, no chest pain. She has had quite a lot of weight loss. She doesn't have heartburn. She does tend to eat slowly with little cracking sounds or air entrapment. She burps a lot during meals. What do you think, just listening to the history, what do you think this could be?
So get stuck a few times a week, we got no chest pain, weight loss. It looks to me like solid food gets stuck with each meal, like hypercontractile esophagus.
It wouldn't get progressively worse. What is typically progressively worse that gets worse with
solid food gets stuck with
dysphagia of solids and fluids? What is typically that does that?
Solid. Oh, I don't like
achalasia. Solid and fluids.
Yeah, achalasia.
Yeah, achalasia. Okay. Yes. So this could be achalasia. So we want to exclude that.
I was only, what got me chipped off a bit was the fact that he said got stuck with each meal. So I was just imagining that part, but it's achalasia.
Okay. And why do I keep on asking these questions of, you know, does the food get stuck with each meal? How often do you regurgitate, in the chest pain and the weight loss? Why do you think we ask these questions? What do we want to achieve by that?
I think on one part we want to establish the severity, and then it also give an idea what stage it is in achalasia.
The severity. So okay, so the reason why we do these certain questions, we use to look at the severity, and also in future for follow-up to see if our treatment was good enough, we use the Eckert score in achalasia. Okay, so the Eckert score, we here you can see, we we give it a count, and then we can see what the severity is with it. And it's a very nice way of once you've treated the patient, when you do the follow-up, because if it's below 3, then we know that it was a successful procedure. So if you're thinking achalasia, just make sure that you always ask these questions so that you can score them, so that we've got an Eckert score to go by in future. Okay, so now I've got this young girl. So what would you do next?
Yeah, because this is a young girl. Although it can't exclude a possibility of a secondary achalasia is there, but less likely because of the age of it. So I may not bother to do the CT scan I
No,
may,
no,
I
no,
think I
no.
will
What
just
is
go
your
forward
next
and
sort
do
of,
esophageal manometry at this point in time for.
no, what would you do before that? Remember, before that, you've just got the history. What would you do
Oh, this is
before?
our first presentation, so I want to do gastroscopy.
Okay, because she's still young, quite often, if one, as I said, if you go to the books, they'll probably say you must do a barium swallow first, but in our setup, we tend to, rather than just do a gastroscopy. Okay, so now we're doing the gastroscopy. So what are you going to look for?
One thing I'll look for is I want to look for food residue
That's right.
in the esophagus, and then I also be careful with the risk of aspiration as well, because if it is a severe one, there will be residual food in the esophagus that can also have the reflux.
Also
and then
see with this gastroscopy.
Yeah, other things I want to see again is I expect to see a narrow lumen at the OGG junction, but then I'll be able to pop in and just opens up suddenly.
Yeah, so in other words, for the scope, you can also quite often see a dilated esophagus, you can sort of feel that. And the big thing is you'll see a tight OGJ, and then if you blow air on it, it won't open. But if you then push a little bit with your
Some pressure.
it has, it goes, gets kind of a pop feel when you go through it. Okay, and with the barium swallow, what do you look for there?
We're looking for the big mouth appearance.
Yes. Okay. So as you said very nicely, you basically covered all the things we were looking for. So in the barium, it's again, you look at the dilatation and you look at the bird beak or rat tail. Some people say it looks like a rat tail. Some people say it looks like a bird beak. And then you can often see the residue of food or saliva. Okay. Right, and here is my high resolution manometry, and I've given my primary one, and I've given 10 swallows of 5 mils. And what do you see here?
So when I'm looking at the IRP again, the IRP is 57, which is significantly higher than our reference range of 18. Then I'm also looking at the contractions as well, and I don't seem to see contractions as well.
Any contractions? Yep, I'll give you a single one so you can see. What does the intrabolus pressure look like?
Yeah, so there is I'm seeing a pan one, yes.
This one.
Yes. Look, this is a pan.
Would you call it a panesophageal pressurization? You must know that I'm tricking you, otherwise I won't answer.
I think I'll call it for me. I will.
Okay. So if you look here, you can see we've set the scale on 30. So if this pressurization was 30
it's
or
30
more,
all through. Yes.
it would have made a little line down there.
Different. Yes.
Yeah. Okay. So it's not. Okay. And so we challenged her, and again increased IRP, no contraction, no intrabolus pressurization. So what type do you think it is of achalasia?
No contractions, no pressure, type 1.
Type 1. Okay, classic achalasia. Okay. So it says the type 1, and she was young, 24.
24.
So 24, and in her case, the type 1, what treatment option would be the best for a type 1 that they found? Because remember, you've got quite a dilated esophagus.
Yes, so for type 1, the surgery is the best option for type 1.
And they found that type 1 does very well with surgery, whereas type 2, it responds well to surgery or dilatation, whereas type 3 really is our trouble. It doesn't really respond to anything. So we actually, the poem is actually indicated in the type 3, because you can then very clearly see up to where the thickening of the LOS sphincter is. Okay, so in her case, we decided it would be surgery. Okay. Right. Case number 4 was a 66-year-old man from the Congo, had a globus sensation and a burning sensation up to his throat. Query was, it sounded like reflux. Intermittent regurgitation symptoms. Symptoms were worse in the supine position, no chest pain. The throat clears in the supine position. So the gastroscopy didn't show any esophagitis. Barium was normal. PPI, oops, sorry. A PPI gave him some relief of his symptoms. So what do you think his diagnosis could be?
It looked like God. Looks like God to me.
But why wouldn't I call it? Why would I not call it GERD? But I'd rather call it NERD.
Well, only because that the gastroscopy showed a normal esophagus, only just gastritis. So
okay.
Yeah.
Right.
I will have been looking at for a classical signs of esophagitis, mostly grade C and B, and then if I'm seeing things like Barrett or strictures, then I will have okay.
Right. Okay. So what procedure would you ask for next? You've got your scope,
maybe before I go for the procedure, I would have said maybe I will increase the PPI and see it's on a single dose PPI. If that will improve his symptoms, and if that don't improve, then next is for me to really confirm if he's having if he's having reflux or no reflux. So we
want to prove, is it reflux or not reflux? And so what would you?
So what I will do, I'm going to stop is a PPI for at least 2 weeks.
Yeah.
Then I will go on to do 24-hour pH monitoring to see.
Yeah, and firstly manometry, and then the pH study. Okay. Yeah. So he's a nerd. Remember, we've got to do the high resolution manometry, because by the time you get a patient like that, you want to get as much information as you could. And so therefore, and we also need the high resolution manometry for the pH placement. Okay, and you said very nicely off PPIs, because we've got no proof of esophagitis. Okay, so I did also send the article of the Lyon consensus in reflux disease. So I think that's a very, very important article that you should read. Yeah. Okay, so now we do the high resolution manometry, and I do my 10 swallows. And if you just like look at it, eyeball it a little bit. Okay, what do you think this could be?
One is IRPE is fine. He's having good contractions as well. And I'm also looking at his
contractions, but look at the DCI.
But the DCI is 28, which is less than 450, but it's more 200, than 228, which is less than 450, but more than 100.
Yeah, so that makes it
that will have fall into peristalsis abnormality.
Into that group, and yes. What abnormality? What one do you think it is?
What I've been thinking of ineffective motility.
Okay, great. Yeah, that's right. So here, if you look at this one, how would you classify it? Would it be ineffective or weak? I mean, failed or weak?
It failed because of the because of the traction, I'm still seeing some of them.
You say that again?
I think I'll call. I know there are two of them. Either you have it failed or weak, and it is based
Yeah.
on the DCI. It said
That's
if
right.
the
So this DCI
yeah.
in this case is 57. So is it weak or is it failed?
So if the DCI is 57, that will be failed.
Yeah, that's right. Okay. And in this case, the DCI is 216. What would it be?
If the DCI is, I want to also look at the DL as well, and the DL is 9.7. So this will be weak.
That's right. Lovely. Okay. And so now I did the multiple rapid swallows. Why do I want to do the multiple rapid swallows?
Because you're chasing the symptoms, since we've not been able to get a conclusive pathology yet. So you want to provoke and see if this is induced or if they are here, just to chase the symptoms and see, and to be sure that it's not OGA junction as well.
And so the multiple rapid swallows looks at the peristaltic reserve. So we want to see if there's any reserve, because if we're going to give him a choice of staying on PPIs, or maybe he would like, some people would like surgery, then you've got to go back and have a look to see if there's reserve, because if there isn't reserve, then they cannot have surgery because they will get dysphagia once they, or you must warn them that they could get dysphagia after a fundoplication. Okay, so now here's my pH study. So my pH, my total percentage of pH that it was exposed to the esophagus was only 0.9, so that's totally normal. My positive, this patient had a positive symptom correlation to this burning sensation that he felt. So with a negative pH but a positive symptom correlation, what kind of reflux have you got to do with here? Condition, rather.
But possibly non-acid reflux?
No. Remember, we just did a pH, so that we only measure acid here, and we know he's off a PPI. So normally your reflux, if someone's a reflux, it will usually be predominantly acidic refluxes. So I want to know if you find a negative pH but a positive symptom correlation, what do you call this? And you're going to see many of them still in your career.
Yeah, that's a negative pH study or positive.
Okay, are we running up?
Hypersensitivity.
Yes, that's right. So it's a sensitive esophagus, right? Okay, and then how do we manage these people?
Yeah, for sense, I have to look for in the I think I'll do more of counseling in these patients. And I didn't think I've seen any treatment, any drug medication treatment for the hypersensitivity esophagus.
Yeah.
Yes.
Okay. So the difference is the counseling actually comes more with your functional. Functional is where you functional reflux is where they basically have negative pH studies and no symptom correlation. But with the sensitive esophagus, the way you must treat it is you keep him on the lowest dosage of your PPI that curbs his symptom of what he experiences as reflux. But then with these patients, we've got to give them what we call modulators. So, and the modulators increases your discomfort threshold. So in other words, so that they don't experience the sensitivity, and that's usually trepoline, 10 milligrams in Noctay, or you can give them a SSRI. Okay, so okay, I'm gonna just basically stop here. So there are another 4 cases, but we can do that in another time. And what I've also put on this presentation is I've got a whole algorithm as to how you must manage dysphagia. I think that's all you should know. And I think we've covered most of the causes of dysphagia. And then I've also added some more literature that you can read. Okay.
Beautiful.
Well, thank you, Sassa. I mean, I was watching the entire time and I just thought it was masterful. And for the fellows, I think the reason Sassa wanted to do it this way, meaning just to give you a little bit of background before going to the case studies, is that as you can see, I don't think, and Sassa agrees, that it's a kind of topic where you guys can sort of read it and try and make it out on your own. I feel that Sassa has been able to take a very difficult topic and make it accessible for you guys to understand. And hence that first 20 minutes of her sort of really explaining how it works in a way that all of us can understand without the background and the history that she's had. I've just had decades of this, of manometry and the experience that comes with it. So I cannot thank you enough. I thought that was masterful. I thought the cases were instructive. It's a pity we don't have time for more, but you know, Sassa has said that if you guys wanted another session at some other point, she'd be more than happy to do this again. So you just need to let me know when you can see when we can fit it in the schedule. But of course, the recording will be available. So please do go back to it to read back on it if you've missed some stuff, and do go to the literature that she provided. Because I think once you understand this, then for the exam or going forward, and even if you get a report from an operator, you won't just take what they say. You'll be able to look at the tracings and make your own assessment of what's going on, seeing that you'd be the primary physician of the patient. So I hope that was very clear. It was very clear to me. I didn't see any questions in the box. Perhaps it's just because it was that clear. Francis, you survived. You survived the tirade of questions. I think you did very well.
Thanks, bro.
And for the guys that are going to be writing the second part of the exam, this is how the exam actually is going to be, the Zoom exam, with a case study and then questions on tracings, the endoscopy, etc., histology. So I think you did very well.
Thanks, bro. Thank you.
I don't know if anybody has any questions, any burning questions or comments from the fellows. If you do, just please put on your mic and your camera. Let's see who you are. No one? Sassa, do you have any parting shots?
No, I just hope my enthusiasm rubbed off a little bit.
Most definitely, most definitely. All right, I mean, if there aren't any questions or comments, thank you once again for pitching up. I really appreciate your attendance. I think it is important that we do it this way. And as you can see, this is an opportunity where we can actually teach, whereas the other Gecko platforms, it's not really possible to do it this way. So the next one is going to be Gerd with Joseph, the fellow, and Professor Fredericks from Stellenbosch. So Joseph, do contact Ernst if you need advice or guidance as to how to go about preparing. And I guess we'll see you in a fortnight.
We'll do that. Thank you, Prof.
Oh, you're welcome, Joseph. Nice to see you. And thank you, everybody. Really, really appreciate it. And really, I love what we're doing. I think it's a good thing. And I hope you're deriving some benefit from it. Karen, thank you so much. And to all the players, thank you to the Gastro Foundation and the sponsors. And I won't belay this any longer. Cheers. See you in about 2 weeks. Thank you, Sassa.
Thanks so much. Thank you.
Bye.
Bye.